But on my heart, there has been a pressing concern for the county. We're number 2 in Prince George's County. That number probably is changing soon. We're number 4 in the state of Maryland for HIV cases. And I think at some point we're going to have a conversation. We're going to have to address this issue collectively. And so this is awesome. We have every organization, or most of them, that have their footprints or some influence on increasing awareness on HIV and AIDS in this room. So take advantage. You've been walking around to the vendors, the sponsors, the speakers are available afterwards, but use this time to really uplift each other, but still, when you leave here, your take-home message really should be, how can I improve the awareness? How can I have a conversation with my families and my friends to get tested? We have a mobile unit on campus that's going to be doing testing, but I'm actually post-call. I had 3 hours of sleep. So if I forget someone's name or if I offend someone, I'm apologizing early.
All right.
And I'm going to eventually turn the mic over to one of my closest friends, colleagues, Dr. Rita Wutu. Dr. Rita Wutu, I've known her for many, 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 many years. She is an internist, a practicing internal medicine physician. She's been in practice in Maryland and serving people for over 20 years. She received her medical degree and her training from the University of Maryland, and she is currently the director of the Henry Wise Health and Wellness Center here at Bowie State University. So I'm going to turn over the program to her as Mistress of Ceremony. Thank you.
Good morning.
It is an honor to host this program here at Bowie State University. On behalf of President Bro and Dr. Artie Travis, who is our division head for student affairs, welcome to Bowie State University.
Thank you.
I am so pleased to host this program today. This is a tremendous opportunity to meet all of the players here in PG County, as well as to network with each other and put our heads together on how we can work together. It's a rare opportunity to have all of us in a room together and to see each other's faces. We might know each other's names, that type of thing, but we really need to think creatively, innovatively about what we can do to make an impact, because every day we're on the front lines here at Bowie State, and it sometimes is a little bit disheartening to see that behaviors are not changing. Okay, so some of the same challenges that I faced as a student, 20-something years, 30 years ago, are still, the students, young women, are still facing those same challenges. So that is really hard as a practitioner to see that we have not made a lot of improvement in that area. As far as women's empowerment, self-empowerment, communication with our partners, that is still a tremendous need, and somehow we need to work together and figure out what we can do to make a change. We have access to the internet and social media now. We should be able to think of something with the help of young people on a college campus to actually reach them and have them be part of the solution to make a change, because as any college campus, chlamydia is our #1 sexually transmitted infection. We know that sexually transmitted infections provide the gateway or the entrance for HIV to take hold. We know that women are more vulnerable in acquiring HIV. We know that pregnant women are still, particularly internationally, but even here in the U.S., are still vulnerable. So, mandatory testing during pregnancy, all of these issues are still, for women, are still pertinent as they are abroad. It's interesting, we were talking about at the table that PrEP has changed things. it actually, people are unfortunately continuing to engage in risky behaviors. So you have men who are having sex with men, or even in heterosexual relationships. Even here at Bowie, when we've surveyed students, only 50% are even using condoms. So it's even less that are using condoms on a regular basis, but only 50%. And of those young women, many are not using any type of contraception. Their response is, well, I didn't get pregnant last time, so, you know, I said, well, how long do you think that your luck will, when do you think your luck will run out? What are your plans for the future? You know, and these are things that we have to continue to talk about, because it's, if you do not take precautions, something is going to happen. Every day we make diagnosis of an infection, you know. People have, we have, just like any college campus, we have the most common infection in women is bacterial vaginosis. You know, so we just have to think about how we can make a change on college campuses. I tell students every day, this is your highest risk of getting HIV, is this time in college. People, young men are thinking, this is, you know, they just got free, broke free of their house, of their parents, and this is their time to explore, to show their manhood. We need to redefine manhood. We need to reach into the communities by age 10 to young boys and talk to them about what being a real man is. It's not how many people you have sex with. It's not, you know, being irresponsible, you know, and so we need to find out how we can talk, engage male organizations, our male students on campus, our male counterparts in the middle schools and in high schools to talk about being responsible. So I just wanted to talk off my heart, really, because I see this every day, and they're not, and it hurts so much when people see and they get a diagnosis, okay, when they find out. So many young women, and I think as you're working, everybody here is in the field, but young women are, for the most part, have one partner. They're in serial monogamy. They're involved with one person. But the same is not true of their partner. And they take those risks because they trust in their partner. They think that that person is exclusively with them. And then they're disappointed. Okay, so let's see. As far as testing, just to touch on World AIDS Day is an opportunity to unite our efforts to stop new HIV infections. It's an opportunity to support those affected by HIV. And we do have students who are affected by HIV on college campuses. And it's also a time to remember those who have lost their lives to HIV-related diseases. And I think that as we just share with each other, we are all touched by HIV. We all know somebody who's infected with HIV, whether it's a family member or a friend. So I'm excited about today's program. We have a wonderful program lined up, and I will introduce our first speaker. Our first speaker is Ms. Tanya McFadder, who serves as a Community Liaison Manager for Janssen Infectious Disease. That's the pharmaceutical companies of Johnson & Johnson in the Medical Affairs Division for 11 years. She's covered over 5 states individually and provides leadership and account management for the Eastern region. In this capacity, she works closely with the AIDS service organizations, community-based organizations, and various public health and private entities to provide HIV disease awareness and education, in addition to specific medication-related education for healthcare providers. Tanya holds a master's in healthcare administration from Pfeiffer University and a bachelor's of science degree from University of North Carolina at Chapel Hill. Additionally, she has 25 years of experience working in public health and health policy, focusing on HIV and sexually transmitted infections in special populations, such as women, youth, LGBT, faith-based community, the incarcerated, and communities of color. In addition to her work in HIV, she is also actively involved in her community and serves on several boards of directors for healthcare and community-based agencies. She's also co-founder of Cementing Foundations Incorporated, which is a nonprofit organization dedicated to empowering and supporting men and their families. She and her family currently reside in the Washington, D.C. area. I'm introducing Ms. McAdam.
First of all, I'm honored to be here this afternoon and for all of you to be here. What I'm going to do is go over some basic information about HIV as it relates to transmission, as it relates to adherence, and a little bit of information about the importance of medication management. So on behalf of Janssen Infectious Disease, we also are a sponsor for the event, and we're definitely happy that we have this opportunity. I do have some slides. I will let you know that I'm going to breeze through these slides probably faster than what you're going to be able to read them. So focus more on what I'm presenting and what I'm saying versus what you see on the screen, just for the sake of time, okay? All right, so we ready?
Yes.
All right, and actually, they have the camera right in front of me, and I like to walk around, so I'm trying to find a spot to stand that I'm still in the visual field. So the things we're gonna talk about today. So we see here an overview. So we're gonna talk a little bit about T cells, right? Or CD4 cells. Those are really the healthy cells of your immune system, okay? We're also gonna talk about therapy. So what it says up here says antiretroviral therapy, or ART. Okay, we used to call this antiviral ARVs, which is antiretroviral infection therapy as well. Lab tests, medication adherence, and resistance. Okay, so we're going to go through some of this. So the basics. What is HIV?
Human immunodeficiency virus.
Say it a little louder.
Human immunodeficiency virus.
Absolutely. So it's a big word, right? Right. So we use the word HIV and AIDS interchangeably, right? But they're actually two separate things. So HIV is the virus that can cause AIDS, okay? Doesn't mean that it will. Doesn't mean in every situation that someone who's diagnosed with HIV will actually get AIDS, but it's possible. Anybody in the room, and I'm just gonna ask a question. Anybody in the room, other than Miss Educator over here who just knows everything, anybody know what kind of defines the difference between the two? Anybody? Difference between the two? I know you guys know this. Okay, go ahead. Okay, go ahead.
HIV is the human immunodeficiency virus, and AIDS is acquired immunodeficiency syndrome. And it's what you have to get before you get HIV. You have to get HIV first before you get it.
Right, absolutely. Go ahead. Want to add something to it?
HIV is the virus, so in a layman's terms, kind of you can look at it under a microscope. I can catch your HIV. I cannot contract your AIDS. AIDS is at a point when your HIV level is so high that your immune system is severely compromised, and things like a cold, a flu, and things like that are the things that kill you, not actually the virus. It's like a depletion of your immune system.
Absolutely, thank you. And that depletion of your immune system, we have a measurement for that, and that's 200 cells. So anytime someone who's diagnosed with HIV, their immune system is working to fight HIV as well as anything else, right? And as a result of that, it's going to weaken your immune system. If your immune system gets weak to the point where you have 200 or less of those cells that are your fighter cells, that yields an AIDS diagnosis. So I'm going to ask another question. What happens if you get an AIDS diagnosis? Does that mean you're going to be sick? Does that mean anything? Anybody know? Okay. Well, let me just explain to you that today many people are diagnosed with HIV and never actually get an AIDS diagnosis because we have treatment, right? And we need people to be adherent to those treatments. We need people to be actively, what I call actively engaged in care. And so being actively engaged in care means more than just taking medication. It's about making sure your labs are done. It's about making sure you stay connected to your healthcare providers, all of them. If you have mental health providers, those as well. A lot of times patients that fall out of care or are not actively engaged the way we would want them to be is because of all of the other social factors that impact their life. Stigma, just going to list a few. Stigma, isolation, lack of education and awareness. All of these things matter in terms of how healthy someone is able to be. Okay? So transmission. I know everybody knows this, but we're going to go over it as well. So there's a couple of ways in which this virus can be transmitted. The first way, blood. Blood to blood, direct blood interaction, okay? Semen or vaginal fluids, sexual fluids, all of those, any of those. Any vaginal, I already said that, but also rectal fluids, and then breast milk. So that means outside of these ways or these modes of transmission, you're not going to be at risk of getting HIV. I'm going to say that again. You are not going to be at risk of HIV, okay? So that means if we have friends or family members or anyone that we know who is infected with HIV, it's okay for us to love on them, right? It's okay for us to prepare meals with them, eat with them, cook with them, share the bathroom. If we're not engaged in any activity where there's a possibility of these things that are listed, there's no way you're going to get this virus from someone else. Okay? So again, based on stigma and isolation, people get this wrong. Even in 2017, people get this wrong. And so as a community, we have to think about the actual ways in which this virus is transmitted and what ways do we do to protect ourselves, to prevent it, as well as support those that we know, or maybe those that we don't even know, that are living with HIV. Okay? When we also think about, in the United States, how HIV is spread, you see what it says? Second, I got a little pointer here, I don't think it's going to work this far. But you see it says, in the United States, HIV is spread mainly by these couple of bullets. Having unprotected vaginal sex with someone who has HIV and who is not taking medications to treat HIV. Again, those that are not taking medications, okay? And also sharing needles, syringes, any of those things that can possibly have some blood-to-blood exposure or some sexual fluids exposure, okay? So, today, we have a lot of folks who are engaging in unprotected sex, right? That means they're not using any barrier method to protect themselves. Couple of problems with that. The first problem is that many of them don't know their status. So, my advice to everyone, and I do patient education across in all of those states you listed, but one of my major things that I educate people about is, because you don't know, treat everyone as if they already have HIV, right? Because that way you can take control over what you do. That means, ladies, gotta use condoms. Got to. The trust factor, the I'm only with him or he's only with me and all of that. If you don't get tested together, and if you're not 100% sure of these facts, it's not about questioning your love or, your relationship or your loyalty. It's really about protecting yourself. So make sure, and men as well, not just ladies, even though I started off with ladies, but make sure you're not allowing anyone else to take your power away from you and protect yourself. So a little bit about the demographics in the U.S. More than 1.2 million people in the U.S. that we know of have HIV, okay? Now, I preface that by saying that we know of because many people don't know their status. We have HIV testing events and mobile units and all of these things for people to get tested. And some of our outreach folks that are in the room, how many times do people come up to you and, oh, I'll do it later, or oh, not today, or I already know, I'm okay, I'm good, and they keep walking past, I've done outreach, I work for this pharmaceutical company now, but not always. I cannot tell you the number of people would, call me in the community the AIDS lady. They would see me walking and they turn around, go the opposite way. So they don't want to talk to me, right? They didn't want to confront their own issues. Because they knew I was going to ask, because I'm kind of nosy too, But it's all out of love. But I was going to ask, and I was going to challenge them on their response. Don't think that you know that you know. Okay? The other thing here, it says women. Women accounted for 19% of the new HIV cases in 2014, and HIV is found everywhere. So don't let someone tell you, oh, I'm from Indiana. We don't have HIV there. I'm from Nebraska. We don't have HIV there. Don't believe it. HIV is everywhere, okay? And globally, in the United States, HIV is a huge issue. Globally, it is an even larger issue. because there's issues regarding access and testing and medications availability and all of that. So honestly, living in this country is definitely a privilege when it comes to infectious disease and HIV, in terms of having access to information and education. So T cells, I'm just going to go through this very quickly. T cells are the cells in your immune system that help fight everything off, okay? It's very critical when you think about any virus or any type of infection, because your body's always in this state of fighting, okay? And that's what your T cells, or I think up here it says your CD4 cells, that's what they do, okay? So we want to make sure we're keeping our immune functioning as strong as possible. I'm going to skip through this. I'm going to show you what it is. Went a little too fast. The life cycle of HIV. Very busy slide. The life cycle of HIV is very, very complicated. So all of my providers in the room, I think you can attest to this. This is high-level science in terms of how this virus functions. But for the sake of time, I'm going to break it down for you. Okay. So one HIV virus is called a viron. Okay. One single cell, one single virus. That viron's whole responsibility, its mode, is what it wants to do, is to impact that T cell or that CD4 cell, get inside of it. Once it's able to attach and get inside the cell, the next thing it wants to do, and it goes through step 3 to 4 on this slide, section 3 to 4. What it wants to do is insert its RNA. So these HIV virons have RNA. What genetic materials do we have? DNA, absolutely. So it goes through a process called transcription and translation, okay? So that viron can remove or insert itself into get our genetic material, which is DNA, so that it can leave the cell and multiply or replicate, make copies of itself, okay? So once this process happens, what do you think happens to that cell? I heard somebody say it. Was that my daddy who said it? It dies. Absolutely. It dies. It doesn't want to be in a dying cell, right? So it goes off. The last step here, step 7, that's the new HIV virus. And it's going to make copies and copies and copies every day. Up to 1 billion copies. This process can happen in your body up to 1 billion times a day. Doesn't mean that it will happen that frequently, but it has the capacity to. That's why HIV, in terms of viruses, is one of the most complex viruses that we are currently aware of, because of this process. And every time it makes copies, each copy does not look the same. Mutations, right? That is why HIV, as a disease state and as a virus, can be difficult to treat. Because from moment to moment, we never know exactly what type of mutation has occurred. The medications work really, really good, you guys. Very, very good. But the medication can only do and kill virus that it can recognize. If it can't recognize it, it can't kill it. Viral load. It's the amount of virus that we measure in a small sample of blood, right? The goal of treatment is to have very little virus. Hopefully at undetectable levels. Have you guys heard of a new kind of initiative or campaign that is called U equals U? Anybody? A couple people? Right. So U equals U means undetectable equals untransmittable. Okay, so if you see it on a t-shirt or a billboard, you're going to see a U with an equal sign and another U. That's what it means. And that's based on some recent data and information that the Center for Disease Control signed off on, and maybe about a month or so ago, maybe 2 months now, stating that, and this is very, very critical information, stating that if someone has an undetectable viral load, we're talking less than 50 copies of the virus, they're not going to be able to transmit this virus to other people, even if they have those risk factors for transmission and exposure that I listed on the other slide. Okay. So that sounds great, right? It kind of supports the data that we've been seeing for quite some time, indicating this, but it's proven now. Now, I say that, and I do this all the time. I always talk about U equals U because I think it's important to get the information out. But I preface that by saying and making sure everyone in the room hears this and understands this, that the only way a person will know that they are undetectable is to, number 1, have had labs done to prove that they're undetectable, and to also be adherent to their medication. So that means if months ago, I had my lab work done, and I had an undetectable viral load. Then a week or so, I was sick. 2 weeks later, I started taking my medicine, and I didn't feel good, and I can come up with all of these reasons as to why. Maybe I was late or didn't take my meds. But then today, I decided to have unprotected sex. Do you think my virus is going to be untransmittable? Probably not. Do you think my viral load still would be undetectable? Maybe, maybe not. So the issue is understanding that this happens, but being sure that a person knows that today in real time, before they go to have unprotected sex, that their viral load is actually still undetectable. Because if it's not, if there's been a blip in the amount of virus in the body, which can happen for a number of reasons, even when people are adherent, you still can have a blip in this virus. Okay? And if that happens, and if there was a blip, there could be amounts of virus that are not at undetectable levels and now putting someone at risk for exposure. Okay? So it's just very, very critical to understand the difference between that. A little bit about therapy, and I'm going to wrap it up. I haven't been keeping track of time, so I don't know how close I am. Okay. This is some information about the classifications of drugs. So there are 4 classifications of HIV medication. I'm just going to read them off to you. Entry inhibitors, NRTIs, which is nucleoside reverse transcriptase inhibitors, and then NNRTIs, non-nucleoside reverse transcriptase inhibitors, integrase inhibitors, and proteinase inhibitors. All of these different classes of drugs work at different steps of the life cycle that I showed you. Okay? The goals of therapy, 2 small, simple things. Increase your T cell count. We want your immune system to be functioning strong, and decrease the amount of virus in your body. Benefits, of course. If you have a small amount of virus in your body and your immune system is functioning, you're not going to have issues. No other complications as a result of this virus or this infection. None of that is going to be an issue. When to start treatment, we're not going to go through that, but we're going to talk about this for 1 second as I wrap this up. Just kind of in summary. These are the things that people need to be doing. Okay, and I think on the slide it may say patients, but all of us, okay? Being open and honest with our providers. Making sure that your providers know everything that happens in your day-to-day life. Regardless of what kind of medical issue or chronic health issue, whether it's HIV or hypertension or diabetes, being open and honest with your providers is only going to benefit you in terms of your overall health. So it's very important, especially for patients that are living with HIV, that they are open and that they're giving all of the information to their providers. Because if providers, and I know we got some providers in the room, so if providers don't know what you're dealing with and what's going on, they're not going to be able to help you to their maximum capacity. Have to know to be able to help. Last thing, we know that medications for HIV as well as any other medications, potentially there are some side effects, right? Doesn't mean that you will experience these things, but these are some common things that we see. I will say that most side effects that most patients receive or experience now from medication is something that may experience in the beginning, when they first start therapy, when they first start new therapy, and gradually, within a couple of weeks to a month, all of those issues typically go away. But there's tons of treatment options. Right now, we have over 30 medications for the treatment of HIV. So I guarantee you that there are medications that will work just about for everybody, that they will not experience any of these type of long-term issues or side effects. Okay, any questions? I don't think I have time for questions, but I will be around. Jansen, we have a table set up over here. And thank you very much for your time and attention, and I appreciate it. Thank you.
So actually, we're going to take a quick break and do a drawing. We have some gifts here. Okay, can I have Miss Tanya, can you come up, please? Betty Milwaukee, can you come up, please? We're going to have you do drawings. And then Torrance Brown, please. So you'll do the first thing. Oh, okay, I'm sorry. Everybody, please pull out your raffle tickets, okay? We're going to be reading off the number. So I'll match it up. Is Aisha in here? Oh, okay. All right, please. Okay.
Okay, so the first one is 593235. All right, congratulations. Okay.
Oh, wait, you said 59335?
593, I'm sorry, 593235. All right. I'm gonna hand that over.
All right.
Lucky ticket. 593301. Yeah. Let me see your ticket.
There you go. Thank you.
All right, 593324. 593324. Is that you?
One more drawing. Actually, while we have our guests up, Dr. Betty Mawakil is the CEO of Access to Holistic and Productive Living Institute. And Mr. Torrance Brown is from Phi Epsilon Lambda chapter of Alpha Phi Alpha.
Okay, so the number is 593328. Hey. All right.
All right, thank you. Our next presenter is Dr. Sarit. She then worked as part of the faculty practice and resident in medical student education at Sinai Hospital in Baltimore for 2 years before going back to North Carolina as an assistant professor at Duke University. While there, she established the Ryan Family Planning Residency Training Program and was its director for 6 years, as well as serving as the Associate Residency Program Director. After moving to the DMV area, Dr. Floyd worked as the Associate Residency Program Director and as the OBGYN hospitalist for Inova Fairfax Medical Campus, while also serving, he's very busy, also serving on both George Washington and VCU campuses. She also served as a Planned Parenthood provider in Falls Church until June, when she became the medical director. She also mentioned to me that she has a 2-year-old, so she is learning to juggle even more responsibilities at home. She's been actively involved with resident and medical student education, has lectured at various institutions and meetings on family planning topics. She began reproductive health advocacy work while at Duke, and that work has continued, increasing after becoming an advocacy fellow with Physicians for Reproductive Health. Dr. Floyd also has an interest in global women's health and has done work focusing on maternal and infant mortality in rural Jamaica, Guatemala, Haiti, and Ghana. I'm from Ghana, so I took the shout out. She's got to come with me on one of my missions, so please welcome Dr. Floyd.
So today is December 1st. Everybody knows today is World AIDS Day. That's why we are all here. As was mentioned earlier, today is a crucial and very important day where people from all over the globe unite to fight HIV and AIDS. We also take the time to support those individuals who are living with HIV or AIDS and to commemorate those who have lost their lives to AIDS-related illnesses. It is amazing how many programs are currently happening, both in the U.S. but then globally, to address this issue because people realize just how significant it is. So we already had a few slides introducing some information that I was going to cover, so I'm going to skim over those for the sake of not being redundant and in the interest of time. And I'm going to get right to some of those numbers that I mentioned to you earlier. So from the video that we just saw, you all saw that 36.7 million individuals are living with HIV globally. 36.7 million people are living globally with HIV. 2.1 million is the number of new HIV infections that were diagnosed in 2014. 1.1 million is the number of AIDS-related deaths that occurred in 2015. But on the flip side, a little bit more of a positive note, 17 million is the number of people who are living with HIV who are able to access treatment, which may not seem like a huge number given the total number of people that are living with HIV, but given where we've come from where we started, that's actually pretty remarkable. 30 million are the number of new HIV infections that were averted in the past 15 years due to the significant scale-up in HIV-related services. And 8 million are the number of AIDS-related deaths that were averted in the past 15 years, again, due to the scale-up in HIV services. And a very important number, 58% is the number reduction in new HIV infections among children since 2008. So that's kind of taking the picture, or getting a picture of what the global impact of HIV and AIDS are. So now we're going to bring it home here to the US. This is a map which depicts the rates of HIV diagnosis among adults and adolescents in the US by state. And this is as of 2016. So an important thing to note is that these are numbers per 100,000 people. And another important thing to note is that the lighter blue numbers are lower numbers, the darker blue numbers are higher numbers. So two really important points that I want you to take home from this map is that, first of all, 45% of the individuals living with HIV in this country are in the South. So almost half of the individuals who are living with HIV in this entire country are all concentrated in the South, the Southeast. And another point I want you to make note of, and I don't have a pointer to kind of show you, but you see Maryland over there in the right-hand corner. So Maryland, you see what color that is? So that's the third highest number in terms of the rate of HIV diagnoses per 100,000 people. So worse than Maryland is Georgia. Equal to Maryland is Nevada and Louisiana. But Maryland, as you can see, has a significant rate of HIV diagnoses among adolescents and adults. This is a graph that shows new HIV diagnoses by transmission category. So in terms of the people who are contracting HIV, how is it being contracted? So as you see, in 2016, there were almost 40,000 new cases of HIV here in the US. 67% of those cases were from male-to-male sexual contact. So gay and bisexual couples accounted for 67% of the new diagnoses in 2016. 24% were from heterosexual contact, 6% were from injection drug use, and then 3% were from male-to-male sexual contact combined with injection drug use. Now we're going to take a look at HIV diagnoses by race and ethnicity. So again, of the 40,000 individuals that were diagnosed in 2016, 44% were African American. Now a very important piece of information to add to this slide is that African Americans account for 12% of the US population. So 12% of the US population accounted for 44% of new HIV diagnoses in 2016. That's to kind of hit home on what a significant problem this is in our community. For Hispanics and Latinos, they account for 18% of the population, and they had 25% of the new HIV diagnoses in 2016. And then the other groups are represented as documented. So for new HIV diagnoses among certain affected subpopulations, this is kind of combining mode of transmission to some extent and racial ethnic background. So the highest rates of new diagnoses happened with male-to-male sexual contact, which we already know from the previous pie graph. But you see what proportion of those were African American compared to Hispanic, Latino, and white male-to-male sexual contact. So again, African Americans being disproportionately represented in these groups. Then when you look at heterosexual contact, African American women were the highest group to contract HIV in 2016. They were 4 times as likely to contract HIV than any other group. Again, serious, serious, serious problem that we have. When you look at by age, when you're looking at by age, the highest age group that contracts new diagnoses is the age group 20 to 29. So exactly the college age group that I'm talking to some of those folks here. But that you see how much significantly higher in that age group too that HIV group is contracting. Now taking it, those were national statistics. Now I'm going to bring it here to Prince George's County. So we opened the program today with a conversation about how concerning it is for the amount of HIV and AIDS that we're seeing here in PG County. But I'm going to put some numbers to it to kind of, again, help bring that home. So 1/5 of all the people living with HIV in the whole state of Maryland live in PG County. 1/5, 22% for the entire state live in this county. We're second only to Baltimore City, okay, which is only slightly higher rates. That number has been steadily increasing each year. It was up 7,100 in 2015 from 6,700 in 2014. So it's not going in the right direction. It's going up, it's not going down. African Americans, again, comprise 86% of those that are HIV positive in PG County. And once again, the 20 to 29-year-old age group has the highest number. And of all the different age groups that were studied, this was the only age group that saw an increase in 2014. So all the other groups either stayed the same or slightly decreased, but the 20 to 29-year-old age group went from 32 to 36%. So now that I've spent some time kind of talking about what the numbers are, what the magnitude of the problem is, I'm going to start to talk about some other really important topics. I'm not going to spend a whole lot of time on transmission because we did have some conversation about that a little bit earlier, so for the sake of not being redundant, I'm going to go ahead and skip over that. But just, again, primary routes of protected anal or vaginal sex, sharing needles or syringes or other products for injection drug use. Less commonly from mother to child or by workers who are stuck by contaminated needles, like who work in the medical field. And then very rarely do you see transmission through oral sex, blood products, like blood donation or organ and tissue transplants. Again, as was mentioned earlier, I think it's very, very important to note that the previous myths that were held around how people can contract HIV, we need to definitively dispel those myths because, as was mentioned, these contribute to the stigmas associated with HIV. So hugging, shaking hands, sharing toilets, sharing dishes, not ways that you can contract HIV. Through saliva, tears, or sweat, also not ways to contract HIV. Through mosquitoes, ticks, or other blood-sucking insects, can't get it that way either. And you definitely can't get it through the air. So being in the same room with someone who's positive does not mean that you are going to contract the illness. So I want to spend some time talking about prevention. We talked about the impact, we talked about transmission. What I want to spend more time focusing on is prevention, okay? Because this is what it's all about. Like, we need to get those numbers in PG, nationally and globally, down until we get them down to zero. So the way to do that, aside from the treatment, is to prevent. Prevention is definitely key. So first and foremost, we talk about this all the time, and we talked about some of the challenges that are faced around this issue, but practicing safe sex. So using condoms is the one thing I have up here, but I'm talking about a couple other ways that you can practice safe sex, because that's not the only way. But that is hands down the most important way. Consistent and correct condom use. If you're using a condom but you're not using it correctly, you might as well not be using it. If you're using it sometimes, but not all the times, you might as well not be using it. So consistent and correct condom use are key for prevention. I want to make a little comment though about condom use in particular, because I get this question sometimes as a provider when it comes to lubricants and what lubricants are safe and can you use them for for concern about HIV transmission. Water-based and silicone-based lubricants are safe to use with all condoms. Okay to use those. Not okay to use oil-based lubricants because they can weaken the condom and cause it to break. What I mean by oil-based, I mean things like hand lotion, Vaseline, Crisco, baby oil. May sound crazy, but in a pinch, people use what they have. So just important to note that if you are using any of these agents with condom use, it can decrease the efficacy of the condom. The other important thing to know, this has come up and something that we're definitely trying to educate people about, is that naloxone 9, which is a spermicide that previously used to be in almost every condom as part of the lubricant in almost any condom package. We now know that naloxone 9 use, it actually increases the risk of transmission of HIV because it can cause a breakdown of the mucosal barrier, so to speak. So very important that when you're using condoms for STI prevention, for HIV prevention, that you're not using condoms that have naloxone 9. Other practices that can, safe sex practices that can help in terms of prevention. So choosing less risky sexual behaviors. So we know that vaginal and anal intercourse in particular cause higher rates of transmission of HIV than, say, oral sex. Between those two, anal sex, particularly receptive anal sex, is the most risky type of sexual behavior in terms of risk for transmission of HIV. So receptive anal sex is worse than vaginal sex in terms of risk of transmission. Vaginal sex obviously is still an important way for transmission, but if you're avoiding these more risky forms of sexual intercourse, or at least protecting yourself if you are engaging in them, then that's really important in terms of trying to prevent. Reducing the number of sex partners. So that's another safe sex practice. So the more sex partners you have, people have probably heard about whenever you're sleeping with somebody, you're sleeping with everybody that they've slept with before and everybody they might be sleeping with now. So if you can reduce the number of partners that you have, then you're therefore overall reducing your number of exposures. So getting tested. It was already mentioned that there's a large number of people who don't know that they have HIV. 1 in 7 people who have HIV do not know that they are HIV positive. 1 in 7. So you look around the room and see how many people are in this room. And when you think about it in those terms, in terms of the number of people here, how many people could potentially be HIV positive and not know it? This is why getting tested is imperative, because you will not know if you don't get tested. I have on here avoiding excessive drinking and getting high. The reason I have that on here is because these are activities that actually cause people to decrease their inhibitions. It impairs decision making, and individuals, when they're intoxicated, have a tendency to be more likely to not use a condom with intercourse, to perhaps engage in intercourse with more than one partner. Or if they are using a condom, they have a harder time using it correctly. So these are some other behaviors that you want to avoid in an effort to prevent your potential exposure to HIV. Obviously, avoiding injectable drugs, sharing of needles, syringes, or any other supplies used with injectable drugs. If you have a partner who is HIV positive and you are HIV negative, we're going to talk about a prevention strategy coming up. But in particular, encourage that partner to get on and stay on treatment, because that is actually a very, very significant way to reduce transmission. For partners who are for someone who's HIV negative who has an HIV positive partner, if their partner is on their medication, taking it consistently, it can reduce transmission by 96%. So that's almost 100%. So having a partner who's positive is very important to stress to them. If they're not going to pass on to you, they need to be on medications, they need to be taking their medications consistently. Pre-exposure prophylaxis and post-exposure prophylaxis, I'm going to talk about a little bit more in detail in a moment. And then mother-to-child transmission. This is one of the most heartbreaking forms of transmission for HIV. I am an OBGYN by training, and I cannot tell you, with all of the different places I've worked and all of the different populations of underserved women who I've provided prenatal care to, one of the hardest things I've ever had to do is to go in and tell a mom who's excited about a pregnancy, came in for her routine visit, came in with an uncomplicated pregnancy, to go in and tell her that she's HIV positive. Because on top of her having to hear and absorb the fact that she has HIV, Now she's thinking, oh my God, what does this mean for my baby? So you're talking about 2 people. So it's extremely important for moms, women who are planning to get pregnant, get tested. Moms in pregnancy, we recommend testing as early in the pregnancy as possible. And then if you engage in risky behaviors, retesting in the 3rd trimester. If you are tested positive, we put you on treatment, and we continue the treatment throughout the pregnancy because that actually can significantly reduce the risk of transmission. HIV can be transmitted to an unborn child during pregnancy, during delivery, and also through breastfeeding. So that's another thing that we recommend for moms who are HIV positive is that they avoid breastfeeding because that is when they can transmit the virus to their child. Now I'm going to go a little bit to testing. I'm going to come back to the PrEP and PEP in a little bit, but I want to talk a little bit about testing specifically. So the CDC recommends that all individuals between ages 13 to 64 get tested at least once. And if you engage in certain types of riskier behaviors, it should be at least once per year. So higher risk behaviors that would indicate that you probably need to be getting tested more often. If you're a male who has sex with men, if you have sex with a HIV positive partner, if you had more than one partner since the last time that you were tested, if you abuse injected drugs, or share needles, if you exchange sex for money or drugs, if you had a recent diagnosis of an STI, chlamydia, gonorrhea, if you've been recently diagnosed as positive with an STI that you may think, trichomoniasis, something you might think is pretty benign, you are at risk, and therefore you should also have HIV testing, along with hepatitis and even TB. Sexually active gay and bisexual men should consider being tested every 3 to 6 months, so stepping it up from every year to every 3 to 6 months. Pregnant women, we talked about the importance of pregnant women getting tested. And then if you have a new partner, that's a great opportunity, a good time for you to go together to get tested, to make sure that you're both in good standing. So the testing types, we've come a long way in how we can test for HIV now, and we've got tests that you can take at home, tests that you can take at home yourself. Tests that we do in the clinic. You don't always have to get your blood drawn anymore for an HIV test. The 3 different ways that testing is done is through antibody testing. So antibody testing means that we are looking for your immune system's response to the HIV virus. So an antibody is your immune system's way of fighting an infection. So an antibody test means that we're looking to see, do you have signs that you've been exposed to HIV? Antigen antibody testing means that we're looking for both antibodies as well as the proteins of the virus itself. So we have testing now that can look for both of those. And then nucleic acid testing is more involved testing that is more expensive and generally is done more through a hospital or clinic setting. But it actually is looking for the virus itself. So it's looking for the RNA that you heard mentioned earlier today. With the antibody testing kits, the home collection kits, as I mentioned, you can use with just a finger prick. The oral fluid antibody self-test, it's a swab of the gums, really easy. And then the rapid antibody screening, which is often done in clinics, also just involves a finger prick. So you don't have to go in for a full blood draw to get HIV tested. So I'm going to talk now about pre-exposure prophylaxis. How many people know what PrEP is? It's pretty good. Pretty good show of hands. So pre-exposure prophylaxis basically is primarily meant for individuals who are HIV negative themselves. It's very important because you cannot get pre-exposure prophylaxis if you are HIV positive. It's pre-exposure prophylaxis. So it's for those who are HIV negative but at very high risk. So someone who is HIV negative but has an HIV positive partner, someone who abuses injectable drugs, someone who has multiple partners and is engaging in unprotected intercourse with those partners. So it's meant for those individuals who are at really high risk to try to prevent them from contracting HIV. It's a daily pill. It's 2 medications that's in 1 pill that you take 1 pill every day. That 1 pill can reduce the risk of HIV transmission from intercourse by 90%. And it can reduce the risk of HIV transmission from injectable drugs by 70%. So that's pretty significant. For some people, this still is a question of, okay, should I use PrEP? Maybe I have some risk factors. I'm not really sure if I fit any of those categories. Should I be someone that asks my provider about it? So these are some categories of individuals that would want to consider, and likely talk to their provider about getting started on PrEP. So if you're a gay bisexual man and you have an HIV positive partner, multiple partners, a partner with multiple partners, or a partner whose HIV status is unknown, but who also has anal sex without a condom or has recently had an STI, then you should talk to your provider. If you're heterosexual and you have an HIV positive partner, multiple partners, a partner with multiple partners, or a partner whose HIV status is unknown, you also should talk to your provider about PrEP therapy. Injectable drugs, again, as I mentioned, sharing needles or equipment to inject drugs, particularly in the last 6 months. If you recently went through a drug treatment program in the last 6 months, those are individuals who also should talk to providers about PrEP. And anybody who just in general may be at risk for getting HIV from sex. I mean, it's not like it's an exclusive thing that you have to meet certain criteria for PrEP. There's certain people it is recommended for. But if you believe that you're someone who's at high risk, then it's better to be safe than sorry. Also, if you're HIV positive, and as we talked about, you're considering pregnancy, you are pregnant, or you're breastfeeding. That's another very key population of individuals who should be on PrEP to decrease the transmission to their child. So post-exposure prophylaxis, so compared to pre, which is before you've been before contracting, post-exposure prophylaxis is taken after you believe you've been exposed. Very important, though, that there's a time window there. You need to start post-exposure prophylaxis within 72 hours of the believed presumed exposure. It is a pill that you take either once or twice daily, and you take it for 28 days. So unlike pre-exposure prophylaxis, which you actually can continue for as long as you feel like you're at risk. You go in every 3 months to get it renewed. You go in every 3 months to get an HIV test and make sure you're still negative before you get the prescription renewed. Post-exposure prophylaxis is for a more defined period of time. It's for about 28 days. And it's very effective, but it's not 100%, and it most definitely does not take the place of other prevention methods, like using condoms, avoiding risky behaviors, some of the other things that we talked about earlier. So now I'm just going to take a couple minutes and just talk about challenges, and this is kind of coming toward the end of my talk. So we spent a lot of time earlier looking at statistics. I'm going to give you a couple more for the state of Maryland. The rate of black males living with an HIV diagnosis is 8.5 times that of white males in the state of Maryland. This is just Maryland as a whole. The rate of black females
Oh, that's all.
I heard something. Oh, he got it.
Okay, everybody can hear me? So the rate of black females living with an HIV diagnosis is 17 times that of white females in Maryland. The rate of Hispanic Latino males living with an HIV diagnosis is 2.5 times that of white males. And the rate of Hispanic and Latino females living with an HIV diagnosis is 3.5 times that of white females.
So why is, all right, I didn't touch this.
This up again is because, it begs the question why? Why is it that we are seeing such significantly higher rates of this condition in our communities? And it's for several reasons, and it's for several reasons that we've begun to talk about earlier that I'm going to continue to talk about now. Part of that is lack of awareness of HIV status. If you don't know you're positive, then you're passing it on to other people, and you don't even realize it. And unfortunately, because there's such a higher prevalence of HIV and AIDS in African American communities, that means that there are more people to potentially contract it from, and hence to spread it on. So that's another problem. It's just the sheer numbers, therefore, the sheer numbers translate into higher risk because there's more people that you could contract it from. There are higher rates of other STIs, and as we talked about, having other STIs makes you more susceptible to HIV transmission. So that's another problem that we combat in our community. A huge, huge issue has to do with poverty, limited resources. So limited access to quality health care, to housing, limited access to education in general, but specifically about HIV, AIDS, and health care. And a huge problem, which was also mentioned, stigma, fear, discrimination, and homophobia. And I'm going to take a couple moments to focus a little bit on the stigma piece, because this is extremely, extremely important. I am reminded whenever I think about stigma related to HIV, I'm reminded of a 15-year-old that I saw once in a clinic that I was working in, who admittedly was having sex with multiple partners and admittedly not using condoms consistently, and came in and wanted to get, an HIV, came in and wanted to get STI testing. She wanted gonorrhea and chlamydia culture testing. So I said, okay, we're going to do that. I said, but given your history and some of the behaviors you're engaging in, we should also go ahead and test you for HIV. And she's like, no, I don't want an HIV test. I was like, why? Why don't you get an HIV test? Because honestly, I don't want to know. Like, if I have it, I just don't want to know. Because if I have it, then I have to tell my parents, and then I have to explain my behavior. It's going to affect how my friends see me at school. I don't want to know. So that stigma is powerful. That stigma is tremendously, tremendously powerful. 1 in 8 people with HIV is denied health services due to that stigma. HIV-related stigma and discrimination, which includes prejudice, negative attitudes, and abuse, is very frequently directed at individuals living with HIV and AIDS. And actually, stigma happens to be one of the foremost barriers to accessing care. It's the reason why people are often reluctant to get tested, like my patient, reluctant to disclose their status to a partner, reluctant to take antiretrovirals. So what does that mean when people don't get tested and treated and don't talk to partners about what's going on? We get expansion of the epidemic. We get more people getting infected. People end up getting diagnosed at later stages because they're not coming in to get tested early, and that translates into more AIDS-related deaths. So stigma is a huge, huge problem and a huge barrier that we're really going to have to face and address if we're ever going to try to make headway with the epidemic, especially that we're facing in our own community. HIV-related stigma results in, like this patient was afraid of. It's a reality, like her fear was a reality, because it definitely results in shunning by family, friends, and community. It can result in poor treatment in educational environments and in the work setting. I mean, it is not infrequent for, it's not unusual for individuals to end up losing a job or feeling isolated in the workplace, not feel like they have any support in the workplace because of the stigma associated around their potential HIV infection. Erosion of rights, psychological damage, and criminalization. And this criminalization is an important thing to note too, because I don't think people really realize to what extent this is a problem. 38 states have HIV-specific laws that criminalize low-risk behavior of people who test positive for HIV. And to illustrate this example, there is a man in Texas who is serving 35 years in prison for spitting at a police officer because his saliva was felt to be a deadly weapon due to the fact that he was HIV positive. So he's serving a 35-year sentence. Now, this is all based on outdated information. So unfortunately, a lot of the criminalization that occurs is based on very outdated information. We've learned a lot more about HIV than when people were first getting diagnosed with it here. And yet, and still, despite the advances that we have in knowledge, in treatment, in testing, still a lot of these outdated laws exist, and so it puts people in a position where stigma can become an even more significant issue because it can result in you ending up in jail. So what can we do about stigma? This is a pretty good little kind of table that was created by avert.org that talks about how you can address some stigma issues. Education is key. Addressing fears, dispelling the myths, educating people about what's real and what's not real, educating them on what we know now that we didn't know before, changing attitudes, empowering individuals to say, okay, you know what, I'm going to get that test because at the end of the day, my health is what matters most, and I have to take care of me. So empowering individuals to be able to take that step, to get that test, to start that treatment that they need to be on. Acting on violations. So this man who's in Texas, taking up the call to arms, the fight. Why is this the case? We know that saliva can't transmit HIV, so why is this person still in jail? So acting on violations that happen. Challenging violence, challenging decriminalization, as I mentioned, anti-discrimination laws, and then working to address key populations that are unfortunately often the targets of some of these same stigma issues. Thank you.